One of the big reasons that chronic pain and chronic illness in general is such a massive problem nowadays is because these types of conditions are almost always complex and multifaceted in nature. There are lots of different elements working together to create that problem. And because conventional medicine has become so highly specialized, you could actually be seeing one of the best doctors in the world and completely resolve all of the issues that they find and still stay sick because of things outside of their specialty that were never even looked at or considered. And so this week I brought in a medical doctor who has a unique approach for treating chronic conditions and over 4 decades of clinical experience to talk about some of the most overlooked and important factors for overcoming chronic illness. Let's get into this. Welcome everyone. I've got a terrific guest for you today. Dr. Eric Gordon is a medical doctor who specializes in complex chronic illness. He's been in practice for 40 years, and the last 20 have been focused almost exclusively on chronic fatigue syndrome, Lyme disease, and autoimmune conditions, which are a huge problem in modern society. Thank you so much for being here, Dr. Gordon.
Thank you, Yoni. It's a pleasure. It really is. I mean, I love your work and the way you approach it, because that's what makes things and people get better, is the approach.
What a beautiful compliment. Thank you so much. So you've got this highly specialized practice, and I'm guessing that when patients come in to see you, they've already been to see a host of other practitioners with various backgrounds. What are some of the things that you see in these people that have been missed along their path to finding you?
Well, usually, I mean, lots of things. But many times they found most of them. It's just that it's the order in which they're approached. But one of the big issues that most people don't pay attention to is structure, is the body, and that's something that's always intrigued me. If I had really known what chiropractic was, when I was a teenager, I probably would have went into it. But living in New York City, it was like, you're going to be a doctor. We didn't think about other things. But quickly on, I was always intrigued because chronic pain always interests me, and it just amazed me what you'd see people who would get good results. And that first 10, 12 years when I was doing more hospital-based medicine, but I would see people in the office who went to chiropractors and clearly got great relief. And so in about 92, I went and studied osteopathy for a year. There was a special program at New York College of Osteopathic Medicine. And that it gave me the tools to begin to feel tissue, see the body, first of all. I mean, because as a doctor, we didn't pay much attention. I mean, we don't care about, scoliosis until you're like till you're like bent at a right angle, then by the time you're affecting your lungs to the point you can't breathe, well, okay, that's a problem. But, little things like, people would walk in with leg length discrepancies that were significant. Nobody paid attention, So, but then as I progressed, and in that same time is when I started treating people with chronic fatigue, because I was always fascinated by the people who we couldn't help in conventional medicine, and we're always told that it was psychological, and I just never bought that, because it was clear to me that psychological just meant what I didn't know yet. In medicine, that's kind of how medicine works. I mean, MS was considered a hysterical disease, like in the 40s, because it didn't make sense,
Which was another way of writing those people off, was it not?
Oh, totally. I mean, that's the old hysteria, or it's anyway. So it's just how medicine has progressed and has evolved. There was a time when there was great respect for the things that we couldn't measure, but as we got better with measurement became the end all and be all. So lab tests and x-rays, and if your lab tests and x-rays are normal, you're normal. I mean, and those are the people in the early 90s that I started seeing. Yeah. is, and they had what now people, yeah, not in those days, fibromyalgia was not accepted as a diagnosis. Now, unfortunately, fibromyalgia is the diagnosis that I think every rheumatologist and pain specialist uses when they don't understand what's going on.
That's such a good point. I talk about it all the time that fibromyalgia is a black hole diagnosis. Having that diagnosis literally does nothing for the patient.
No, no. I mean, they have three medicines that aren't really for fibromyalgia. I mean, they affect, the nervous system and pain sensation. So they do have some benefits to some people, but they're band-aids at best. Mm-hmm. And I say that's what I call, actually a good part of what I do, I call band-aid medicine, which is not bad. I mean, when you're bleeding, it's nice to have a band-aid. When when you can't sleep, you might need something to help you start to sleep. But the problem is we stop there. Instead of that being the first step in medicine and healing, that's the final step.
That's such a good point, Dr. Gordon, and I would love for you to expand upon that. So the concept of band-aid medicine, which I would refer to as emergency care. And the United States is fantastic at emergency care. Like if I get hit by a bus, there's no place I would rather be than in a top-notch hospital in the United States. But yeah, what you just said was it stops there. Talk a little bit about that.
Well, it's the way we have thought about it. Medicine has progressed from warfare. I mean, every time we've been in a war, we learn a lot. I mean, that's why getting hit by a bus. Thank Vietnam. I mean, and every war since then, because we got really good at saving people who were pretty well battered up. But what happens is that even in things like, well, basically all the chronic illnesses, from diabetes, cardiac disease, and all the autoimmune diseases, it's kind of the same thing. All these cool new biologics that are out there. And biologics are these antibodies that kind of stop the inflammatory molecules that are causing things like, rheumatoid arthritis or, stuff of that sort. They are great. They're head and shoulders better medicines than probably just keeping people on prednisone for a long time. Or, but still they're band-aids. They don't deal with why your body is stuck in this reaction. They just go, oh, this reaction is there, we're going to stop it. But that's the end of the line. That's not what's causing it. So we managed to have, a huge population of people who are walking around, which is better than not walking, but they're walking around on a ton of medicines and they're not healthy, but they can function. And for the vast majority of us, being able to function is really good and really important. So it's good, but we have to do a lot better. And when people come see me, they usually have illnesses that the Band-Aids haven't or don't work for.
So that's exactly why I wanted to talk to you, because your practice has expanded beyond this concept, or it integrates Band-Aid medicine, which, as you said, is fantastic. There's a time and a place for it. And as you said, the perfect example, if somebody's miserable and you give them one of these things that allows them to not be miserable and to get some sleep at night, well, then you're setting them up for long-term success. But only if you take that next logical step and say, what is causing this situation?
Right. It's going underneath. And, in my world, chronic infection, chronic toxin exposure, is probably the biggest. But the third part about that's really not recognized much is the structure. Is because what happens is that if you've been, just living a modern life, we don't walk nearly as much. I mean, just imagine life without a car and life without a bus, and you just had to walk all the way everywhere you went. The exercise, I mean, the movement. I'm not about building muscle, but you're pumping stuff. But on top of that, we now have all our devices.
Sure.
And we had typewriters and telephones, and now we have computers and iPhones, and and we live on them, and that just keeps ourselves crunched up. And this area, I mean, this is I focus here. Really, it doesn't really matter because you can probably teach me all about that. But it can just be a bad ankle, and the whole structure is going to be off. but it's when it finally reaches the point that there's excess tension in the neck. And welcome to America. I don't know how many people don't have excess tension in their necks and shoulders. Well, it impedes blood and, more importantly, lymph. Okay, because what people don't get is that, you know, the blood flow is to get in and get out, but the lymph flow is what removes a lot of the toxins. And so many folks we see come in with pressure in their head, or just a lot of symptoms that have a lot of neurologic components. Okay, and if there's not good blood flow and good drainage, those continue to get worse. And despite the best medicine, you know, despite other treatments, or even, like I said, you can try to remove the infections or the toxicants. But many times when people start getting sicker, even treating things or moving toxins will make people feel worse. Now, partially that's because their guts and their livers are stressed, but also they don't get the drainage from the brain. And so once you start getting a little inflammation in the brain, okay, you start making toxic materials. And if you don't do anything about it, in 40 to 60 years, you wind up with, you know, dementias, Parkinson's, all the movement disorders, all these neurologic diseases. Okay.
I want to go back a step, Dr. Gordon, because
sure.
I respect so much your clinical approach here, and I relate to it very profoundly, because it's exactly the same type of clinical approach that I take when you have these complex conditions walk into your office, and they've already been given a bunch of different labels and a bunch of different diagnoses. But what you're doing is you're not looking to label or diagnose this person. You're literally looking at, what chronic infections does this person have that I can address? What structural issues does this person have that I can address? What neurovascular issues does this person have that I can address? What lymph drainage? So you're literally lining up a checklist for yourself of, these are the things that are potentially contributing to this person's problem that are suboptimal, and I have ways of easily addressing most of these things.
Well, not always easily, but we have ways, and you know, and that is what I always, my message to people is that, because so many of them have come and I've already tried a lot of this, you know, so it's not that, and it's not that I have ways. I often know people or have people in the office that know how to address these things.
Sure.
I know how to do them. You know, I know how to do most all the things they do fairly well, but you know, you see, you know, when it's repetition is what teaches you.
Sure.
You know, and so it's always good to have people who are expert at these different modalities, and different modalities is the most important point here. Is don't, if you have been you know, to various body workers and it doesn't hold, well, something else is going on. You know, probably there's underlying inflammation, which is, we'll come back to, because I'll talk about how much that can really affect the structure. But it's finding the right modality for the right person. And I always wanted to have a sign on my office: everything works sometimes, which is really kind of frustrating for folks, but it's true. What you read on the internet, they're usually not totally making it up. You know, I mean, everybody out there who's selling what they do has helped people. You know, I really believe that. It's just that the thing that's frustrating is it the right thing for you? And that's where I would love to get doctors to learn how to be triage. You know, I mean, like the triage nurse in the ER, like, decides like how sick you are and which person you should probably see first, you know. And it's the same thing. That's what we have to do, okay? Because we can't do everything, but we have to recognize these things. You know, we have to recognize that there are some people who, you know, maybe muscle energy is the right way to go for them, or just more cranial work for them, you know, more subtle energy work for them. Because there's lots of folks who, if you change things too quickly, I mean, again, this is going to my world again. The thing about people who come to see me, they've usually reached the point that interventions are no longer risk-free. I mean, well, most interventions aren't risk-free, but for them, I mean, these are people who, they take vitamin C and they get sick.
Mm.
So, we have to be careful how we stack what we offer them,
Sure.
because it's as you've been sick long enough, your body becomes more defended.
Yeah.
Okay. You come into the world, that's the unfortunate thing, is that some of it's just how we come in. Some people you can hit on the head with a 2x4, and some people like you smack, and you'll hurt them badly.
So you're talking about how much threshold a person has before they start spilling over into symptoms.
Yeah, or how badly we in our world we say how easily they crash. Okay, because and it's so funny. There's some people who can take drugs with no problem, and they react badly to herbs. There are other people who they do great with high velocity work. I mean, for acute things, and other people that's terrible for them. Even the most subtle cranial. I mean, one of the reasons that I personally I use cranial to assess people, but I don't treat a lot of people, is because as I started treating more and more sensitive folks, I could think they were doing great in the moment, but then they'd go home and feel terrible because I moved too much.
Yeah,
Because
cranial work is
I
so
wasn't
powerful.
I wasn't subtle enough in my
Yeah.
own sensitivity to know when I've done enough. Because the system seemed to be happy in the moment,
Yeah.
but it couldn't. You need someone who is aware enough to know that even though you're smiling, it's like a good meal. I've already overfed you.
I, I can relate to that again very much. I always talk about it in terms of margin for error. When a person has been struggling with a condition, and in my world, it's chronic pain. When a person's been in chronic pain for so long, you have to be so careful how far you push them. And again, what you said about being so sensitive to the input that you're providing to that system, and then documentation, so you know exactly how much you gave and then exactly how much you're going to ramp it up the next time you work with that individual. So
Yeah,
right on the money.
it's right. But again, and it's different. There are some people who you can just like push through. It's like when people come to me with Lyme disease, I say, you can go to for treating Lyme, the front door is, here's some antibiotics or herbs, usually even, if they're really sick, antibiotics, if they have a lot of neurologic symptoms, even IV antibiotics. But most people that by the time I see them have already tried that, and it didn't work. For many other people, it works perfectly. I mean, that's what's, I think, disturbing out there, is that there's so much patients have gotten frustrated and angry because they're not getting, they were treated and they didn't get better. And what they have to understand, and when that's happening, it's because we're still not getting to a subtle enough level in their system.
Yeah,
What's nice.
and,
Yeah,
and
so,
that's that's the art side of healthcare, right? That's that. And one of the things that you've mentioned a couple times, which is absolutely fascinating to me, coming from a medical doctor, is how you're monitoring the patient. Because typically when I speak to friends or patients of mine who are medical doctors, they're talking about monitoring blood work or monitoring imaging studies, things on a piece of paper. But you were talking about the patient's smile or the look on their face. So you're reading body language, and that's what I read, is all of the nonverbal communication. And the more years
well,
of practice that I've had, the better I get at reading those signals from the patient.
but actually, even more important than what I'm seeing them is what they're telling me. It's
Sure.
because, like I tell people, you're on the inside.
Mhm.
You know what you feel.
Mhm.
Okay. See, our tests are designed for near-death experience. Okay. When you get that chem panel, whatever people call it, every lab has a little different name for it, but 12 or 14 chemicals that tell you about your kidney function, your liver, and your electrolytes, and then you get a blood count. I mean, those are things that are off when you're going to die.
Mhm.
Okay. But you can be chronically ill and feel miserable. Okay. But those tests can be perfectly normal. Your innate immune system. Okay. Your natural kill, well, not even your neutrophils, your macrophages, all these white blood cells that are there to defend you at the first hint of danger. Okay. They can be going off in small parts of your body, and your chem panels are going to be perfect. Okay. But you can feel miserable. Okay. Because, there's a bunch of these chemicals that we talk about, cytokines that people since COVID hate to say there's benefits to COVID considering how devastating this illness has been to so many people, but still people have learned a lot, and I mean, scientists and lay people, and learned the language a little bit. And that for that inflammation that kills people in COVID, well, the CBC can be off, but lots of the other tests are perfectly normal, because we've had to get subtler and subtler at our testing. And that has not really come into mainstream medicine much. Okay. There's still, when you go to the doctor and you just say you're tired, they'll measure your blood count. And if they're good, they'll include your thyroid and, in that CMP, or that comprehensive metabolic panel. And if that's normal, they're kind of done. They'll talk to you about, a little less stress and improving your sleep, which are all good things, but they're not looking much deeper into what's causing problems for you. And chronic inflammation is missed because very often if you really just come in and like you're achy and inflamed and tired, they might do a sedimentation rate and something called the C-reactive protein, because those are markers, those are non-specific markers that part of the immune system is upregulated or inflamed. But even those are absolutely normal in a lot of these people. Okay. And the other testing is often either not covered by insurance or is not believed by other doctors because they didn't teach it. They didn't teach it to us in part of our real day-to-day clinical training. You learned about these things in school, at least they do now, because when I was in training, we didn't even know about half these cells. I mean, half these things in the immune cells. I mean, in the immune system, it's just amazing what we've learned. But so inflammation. And the thing about inflammation, it will affect your structure. In some people, a lot. And that's one of the big things that, I should say, big, small things. Okay. Big things for some people, okay, is there are people who tend to be a little more flexible than others. And that's something I really want to talk about because, we didn't pay much attention to that. And then Dr. Shoemaker, who's well known in the mold and mycotoxin world, he is a very astute clinician. Don't always agree with his approach, but he's a very, very smart doctor. Okay, and what I mean, he's really great observer, and he noticed that some of his sicker patients seem to have what he first noticed, they had a longer arm span than, which happens to go along with connective tissue issues also.
Sure.
That got us beginning to pay attention. And I just noticed in my clinic, because of my love of osteopathy, I would always check, people's range of motion, especially in the hips. Okay. And I would see these folks who are 50 years old, 60 years old, even 70, who had as we get older, that hip, that internal rotation in the hips kind of goes. I mean, hips get tight.
Yeah, hip internal rotation and extension are the first to go.
Yeah, and so that's why people can't sit cross-legged anymore, or if some of them never could, Yeah. But these people, they were really mobile in their hips, and I was always wondering about that. And to be honest, and we started seeing it more and more, but I didn't. And some chiropractors mentioned to me that people in allergy season didn't hold their adjustments as well.
That's really interesting. I had an observation that I've made just over my years in practice, which was that somewhere around 1/4 or 1/3 of my patients had what I called a more floppy constitution. Yeah. And so if I was to run something like a Beighton score on them, where I'm checking like wrist and finger and elbow and knee flexibility, you start seeing like hyperextension at the elbows and hyperextension at the knees. And you're saying, well, this is a global phenomenon that we're seeing with these people. So it's either inflammatory related, or it's like that joint hypermobility spectrum where you're talking about that increased arm span, and you're talking about things like Marfan or EDS.
Ehlers-Danlos is a big thing, but and for people who are interested, Ehlers-Danlos become a big thing, but it's a little bit, unfortunately, like fibromyalgia. And there's a small subset of Ehlers-Danlos that are clearly genetic.
Sure.
But most of the people who have symptoms that are consistent, they're on the Ehlers-Danlos spectrum. We don't have the genes for it. It's just there's probably a lot of things that lead to it. But what we definitely see is if you're on that spectrum and you wind up with a chronic inflammatory condition or a chronic toxic condition, you often have more trouble getting well, and B, that can you get more flexible. I mean, people start, and again, this is a spectrum. So luckily, I'm talking about probably a 1 or 2% of people at the end of the spectrum where they actually start having more shoulder dislocations, when they start getting inflamed. And what's really been a big thing is variations on excess motion at the upper, where the occiput, where your head sits on your neck, and those first 2-3 vertebrae. And you'll often, and the only thing you'll get a plain X-ray, and the only thing they'll notice, straightening of the cervical spine, because you're supposed to have a nice little curve,
That's right.
C curve to the cervical spine. Well, that often disappears in these people who are a little more flexible because their muscles are having to be tighter.
That's 100% right on the money. So let me just jump in with a couple things here. So my observation was that it was roughly 1/4 to 1/3 of my patients who had this more, what I call the floppy constitution, where they were just hypermobile in their joints. In preparing for our conversation, I did a little bit of digging. I found a 2020 study that talked about what percentage of the population is on that hypermobility spectrum. And as you're saying, there are some people at that far end with those extreme versions of Marfan and Ehlers-Danlos, which are a spectrum of disorders in and of themselves that have that really devastating version where it affects blood vessels and their heart and all of these types of things. But as far as the amount of population, the percentage of people that are on that hypermobility spectrum, it's as high as 38.5% of the population that's on this. And so when you're talking about these people then subsequently get a pro-inflammatory condition, and it's a whole nother ball game.
And and that's it, because the thing is that the spectrum is the important part. Because even the Biden score, I mean, the Biden score was something that probably Dr. Biden, I think, put together. But it looks at 9 joints. But people can have normal Biden scores and still have problems. I mean, because that's what we have to always. A side note: medicine is full of rules. Okay. And we need them because there's too much information. But at the same token, we got to remember that most of the stuff that we're taught in school, it just got made up. It's not physics. Okay. It's not like building bridges where, like you can look at the numbers and, an engineer can look at the plans and they're going to stand or they're not, the building's going to shake or, no, with people, there's too many moving parts that we do not understand. So, if you're feeling bad, believe that you're feeling bad. Don't believe the test that says that you don't have that problem, because you still might.
There is so much humility and wisdom in what you just said.
Well,
that's a really important point.
Yeah, well, when you just listen to people's stories and believe them, I think that, well, I don't know too much about my philosophy of medicine, but the other thing you're taught in medical school is, well, I'm going to date myself. There was an old TV show, Columbo, where just the facts, ma'am. I actually goes back even further, Dragnet. I mean, it's just, it's not like that. When I want to make sure whether you have a heart attack or not, well, we can, even then it can be wrong, but we're going to be right like 99% of the time with the hard data, 99.9. But when it comes to chronic illness, it's what you're feeling.
Sure.
If it doesn't make sense to me, we have to look harder. See, because patients generally don't. That was my point I was trying to make, is we are taught in medical school, because we are trained in emergency rooms.
Yeah.
Okay. And emergency rooms, unfortunately, in the last 50 years are filled with people who yeah, have emotional, mental health issues, drug addictions, or often people who are just trying to game the system. And you begin to think that that's what's out there, but that's a small percentage of people. Most people who come to the doctor are coming to because they don't feel well. They're not looking to waste your time. But see, the emergency room milieu is full of emergencies, people who are dying, and other people who are coming in because they don't want to go to work tomorrow. And I don't mean that it sounds terrible, but that's what happens. So the doctor gets jaded and stops. If the X-ray doesn't show something or the blood test doesn't show something, they just want to get you out the door.
Yes.
And that's your training. And that's what the problem is. That's why when you go to the doctor and your tests are normal and he kind of like even respectfully blows you off, it's from that past training instead of going, wait a minute, there's another human being sitting here telling me they're sick.
Yes.
And I should listen, and if I don't know what it is, I should keep looking. And to be fair, most doctors try, but we're not given the tools. The tools that we are trained with in traditional medical practice are not designed for people who don't have things that don't show up on the blood tests that are normally run. So it's this.
You're kind of looking to put somebody into a box, like
yeah,
put them into this box and put them into that box.
Now, what's happened is that over the last 20 years, especially, more and more, there are more and more tests out there that can help detect subtler findings. Okay. Now, okay, I don't want to go into this too much. And the problem with those tests is that they're not as well validated. I mean, it's not that what they're measuring isn't real. I mean, they are measured, but the question is, what is the meaning of those tests in your body? Just because ABC cytokine or ABC mycotoxin is there doesn't mean it's causing your symptom. Okay, doesn't mean that it's even significant, because a lot of these tests haven't been run on 1,000 normal people or people who we clearly are okay. They've been maybe run on 10 or 100, and then they say, oh, that's normal, and then it's not good enough, the tests that I use. But with the person's history, I think that they really can be very, very helpful. I hope I just wasn't very confusing to people.
No, not at all. But getting back to the hypermobility that you were talking about. So we're talking about people that were not at the far end of the spectrum where it's an obvious genetic issue, but they're still on the spectrum of hypermobility. So when you're looking at their clinical presentation, what type of symptoms are you seeing with these people?
Well, again, I'm seeing them because they're inflamed. Okay. People, 99, I can't think of everybody I see has chronic inflammation, because that's just what happens when you live long enough, and you're not able to put out the fires, well enough.
And you're determining that they're chronically inflamed based on blood panels?
Basically symptoms. I do blood tests that do validate that. Because what we're looking at is tests that test various aspects of the innate immune system often, which actually now we're getting better. We're able to get more and more tests that look at subsets of T and B cells, which is called the acquired immune system. And we can see imbalances. What happens? Very simple, long COVID. Is a good example. Now, there is a strong suspicion that a lot of people with long COVID have, they begin to, many of them get reactivation or increased symptoms from latent viruses, especially Epstein-Barr. That's a big one we know about. Okay. And one of the reasons people think that happens is because they develop what they call T cell exhaustion. Which means that and again, it's not all your T cells. There's like lots of different families of T cells, but that the natural killer cells and one or two other subsets of these T cells, these immune cells, are no longer functioning optimally. Well, yeah, and when that starts to happen, inflammation goes up, and the other inflammation goes up because the immune system is a very well choreographed dance. Okay, so when you get an infection, the innate shows up real quick the first hours and days, and then this acquired immune system is supposed to come in and finish the job, and also give the signals for everybody to quiet down, for those initial innate immune system to quiet down. And people use the army, like this is your army, so to speak. And so you got to tell the troops to stop firing. And what happens if there's an imbalance in the system, some subset of your defense system keeps firing, except there's no more enemy anymore. It's just hurting you.
Sure. So if you're using those types of blood tests to confirm what you're already getting from the patient's symptomatic presentation, what types of things are you seeing clinically that are right in front of you when
well, see, this is why it comes down to. It just depends on your body. Is it your liver that's a little more aggravated? Often, of course, the intestine is a big part where there's constant inflammation, and then that lets more chemicals in. The liver has to work harder. It gets tired, or it could be your kidneys. It could be your heart. It just could be, for most people, it's the joints. Those are things that get a lot of wear and tear, everyday use, and a lot of healing. And so you get some places where that healing doesn't complete. And if you have a chronic infection that's localized somewhere else, but it has disrupted this immune balancing act, this immune choreography. Like I said, and once you have these so-called exhausted T cells, well, this other clones of T cells, these T helper cells that should be at like 30%, now bump up to 60% because they're trying to compensate. They start to take over some of those functions that these exhausted T cells aren't doing, but they don't do them as well. Okay, so you're sort of like instead of fixing something with a screw and a nut, you're using tape, and the tape doesn't work as well. So it's imbalance. So you're left with an imbalanced immune system, and you wind up with chronic inflammation. And this can be low level. I mean, the body is so amazing that you could have low level inflammation for decades with no signs, except you're slowly developing atherosclerosis. It doesn't have to be you have a lot of pain. I mean, you can have subtle they're not so subtle when it's atherosclerosis, but it's subtle because you don't feel it. But getting back to a structure where we're talking about, this inflammation makes ligaments a little more lax because some of the chemicals that your body releases, I mean, you can see it really clearly if you get a mosquito bite or a bee sting. It swells.
Sure.
Yeah. Okay. It swells because you start releasing chemicals that make that make the tissue a little more in that local area a little more less held tight together. Well, when that happens in connective tissue, it gets a little more lax. That's why I said allergy season, you get your mast cells, your eosinophils, these inflammatory cells to release chemicals that affect the connective tissue. So they get a little more lax. And we're talking micrometers, I mean, they're not like, inches, they're tiny bits, but this is a pretty, again, it depends on things working fairly well. So if you get a little more laxity in your ligaments, okay, that means that your muscles, because ligaments go from bone to bone, and you can tell us much better than I about how someone can stand with almost no muscle tension if they're lined up.
Yes. So the way that the secondary curves of the body are designed, so like I have a 12-month-old, and right. The first of the secondary curves that forms is in his neck, so that when he's looking around for comfort or shelter or food, he has freedom to move his neck in all directions. And the reason that happens is because of that formation of the secondary curve, which lines up the facet joints and allows us to hold the weight of this, 10-pound head, this bowling ball on top of a golf tee with a minimum of muscular effort. It's all an efficiency model. And now he's about to walk. He's standing up unassisted because of the formation of the same type of secondary curve in his lower back. So the lower back curve and the neck curve both do the same thing. They support a very heavy structure on top with a minimum of muscular effort so that energy could be directed to other things like collecting food to help ensure survival.
Yes, and that, but the trick here is that the muscles aren't doing much work. You know, right. When you're in good alignment, your muscles don't do much.
That's right.
But when those ligaments start to get a little, just I mean, microns a little laxer, your muscles then take over. Okay,
100%.
and that's
there'll be a danger signal associated with the loss of stability.
Yeah. Okay. So right there, you've got, so now you have more noise going into your system, you know, just information, because your body is constantly reading where you are in space and how you're holding yourself. Yes. And so those ligaments, they get a little more lax. Now, that can be, okay, that's not good. You get a backache, you get a neck ache. Okay. But when it's when it's happening at this first part of the neck, you've got all these nerves coming out, okay? And you've got your vagus nerve, which is actually coming out of the base of your skull, but it is going through these muscles. And when everything is tight and irritated, okay, you start to get noise, okay? Because you depend on your body to kind of tamp down most of the information that comes in, okay? There's too much information coming in. You really don't want the higher centers of your brain to be bothered with breathing and with heart rate and with all this stuff. That's all being controlled in, more or less, in your brainstem. I always have to be careful.
Our autonomics here.
Your autonomic nervous system is all, well, but if that area at the base of your skull has a little tiny bit more mobility, okay, it starts releasing inflammatory chemicals. I mean, we're not even, the biology of what's happening there is in its infancy, okay? Sure. But it's clear, what the end results are clear. The autonomic nervous system is not doing well. So your gut doesn't work well.
And I'll just piggyback onto what you're saying, which is the highest concentration of proprioceptors in the body is right there where the neck meets the skull.
Right.
And so you're getting the most amount of input per, you know, area. Yeah, that's exactly right. And then the other thing that's happening there, which is what you mentioned earlier, is when you lose that normal curve in the neck, you ramp up muscular activity like crazy. It's 10 times the muscular effort for every inch that the head shifts out in front of where it's supposed to be. So it's not just the loss of ligamentous integrity, it's also the forward head position that is contributing to exactly the process that you're talking about.
Yeah. And so you get, so now this is, and so most of the people I see, almost everybody, in fact, again, if you're an American, I mean, just look, very few people have you know, ears over their shoulders.
That's right.
You know, so, but when you add this chronic inflammation and those ligaments start getting a little more lax, okay, you get to the point where you're really impinging some of those nerves and causing massive problems. Now, people who get, I mean, again, we're talking about continuum again. I don't want people running out there going, oh my God, you know, you're not dying. But we see people, the far end of the curve is something called cranial cervical instability. And, you know, and the far end of that, people require surgery for. But there's a lot of us, thank God, you know, like it's not so bad. You know,
let's just explain those words to people who are not familiar with
them. Well, cranial cervical instability is, I said, the cranium, your head, okay, being a little unstable on the very top of your cervix, your cervical spine, not your cervix, your cervical spine, and that can affect, I said, the very basic part of the brainstem, and it also can affect the nuclei, the brains of the nerve, if you will, of the vagus nerve. Okay, the part, so I mean, it's not the long track, but it's where the really the nerve bodies of the vagus nerve live. Okay, and that leads to all kinds of autonomic things, which make doctors crazy, because people come in and they have palpitations, they have rapid heart rates, they go to the doctor, they go to the cardiologist, and you know, they get the monitors and they get the echoes and the tests, and they're basically normal. The monitor might show that they have some arrhythmias, but these are usually what we call benign arrhythmias, like the heart's racing, it's going fast. Well, the problem is if your heart's going fast when you're walking from the kitchen to the bathroom and you're hitting 130 beats a minute, you're going to be pretty tired.
Yeah.
Okay. If your average heart rate is like 60 to 70 when you're sitting, and it starts hitting 120 when you're walking around, you're exercising, but you're not getting any benefits because all you're doing is you're not using your muscles much. So, but it leads to exhaustion, and feelings of shortness of breath, not being able to breathe right, and probably the biggest, most misunderstood part is your gut. Okay, because your vagus nerve goes to your liver, your stomach, your gallbladder, your small intestine, the beginning of your large intestine. I mean, and if it's not happy, and our guts are already, you remember, are a mess because we're Americans and we're eating junk. You get into a lot of problems that are not noticed because unless this becomes so severe that you're bedbound from it, and that can happen, people can develop really to the point where almost all input becomes painful and noisy. I mean, talking hurts, visual, I mean, just they want to wear, you want dark, you need silent. I mean, like the whole nervous system is in an uproar. But that I said, that's a far extreme, but that can happen. And people, I mean, like family members take care of these folks. And I remember when I first started, I didn't know what to do with these people like 20 years ago when I would see them. I was like, we would try all kinds of subtle stuff. And sometimes we'd be lucky and something we'd move things. But if it's from craniocervical instability, not much helps. Now, that's not the only reason you can get to that state, but it's one of the common ones.
Super interesting. I saw a case study years ago from a mentor of mine who was dealing with somebody who had those really extreme inputs where everything was just firing off that person and there was almost nothing left to do. And he ended up resolving the person's situation by putting them into a body cast. You're talking about like complete body, and your face lit up because it makes sense. But I would have never thought of that in a million years. And he presented that case and it blew our minds. I don't remember how long he had the person in the body cast, but it did resolve the situation. But you're talking about a total lack of input was the only thing that could resolve the situation.
Well, hopefully we kind of do it differently. We just fix the neck and that resolves a lot of the situation.
But explain what you mean by fix.
Okay. Well, unfortunately, people are working on ways now of using PRP, like injection techniques, but those and again, for people who are on the subtle, who are just beginning, they often really work quite well. But when it's really severe, the final solution is they actually put in a piece of metal that just goes from the base of your skull to those first two vertebrae and fuse that. But that's, I said, extreme. We don't want to go there. But
that's actually one of the things that I wanted to share with you was the concept of using an active traction unit to strengthen the surrounding musculature to take up slack in the people that are at that earlier end of the spectrum, where maybe you can catch it before it becomes a surgical case, and you can strengthen the muscular system to help bolster the ligaments and maybe buy yourself some time to calm down that inflammatory process. That's
interesting, because they say because usually we wind up with people whose muscles are so tense that they're actually making it worse. But but again, I have to look at but again, their muscles are tensing because of usually a self-defensive stress rather than
I would call that
splinting stress.
I would call it splinting. So you would be getting splinting of like the suboccipitals, but if you could strengthen the muscles that are actually the ones that are primarily responsible for that task, then the suboccipital splinting would actually offload itself.
Oh, and that would be great, because the big thing about this is that what makes this so difficult is that many people who get into this mess get into it because of inflammation.
Mm-hmm.
And what one of the buzzwords of now is this mast cell activation. And mast cells are your oldest immune cells. They're the guys who came first in the cascade of development, from single cell organisms to like us. Not that we're necessarily the top, but anyway. And so the mast cells are everywhere. And we always thought of them in terms of allergy because that's when they make the most noise, but they're part of every immune response in the body is got a mast cell stuck in the middle somewhere. Okay. And they're in the brain, and they're on around our nerve cells. And so once these mast cells, if you have chronic inflammation, sometimes, and the right genetics, those mast cells can start going all the time. And because they're constantly going, they're creating inflammation, which is making those ligaments a little more lax. And then when it's happening here, that danger signal, okay, because that happens because when you have inflammation here, it's affecting the vagus nerve, which again, when your heart starts to beat fast, that's a danger signal. Okay, you can be the most relaxed person in the world, but your heart's rate is going 130 a minute when you're sitting, you're going to feel anxious because that's just how the system is wired. So that's why I always want to remind people, oh, I'm so anxious, but maybe if you got your body quieted down, you wouldn't be quite so anxious because you're getting all these crazy signals. You don't know where you are in space.
Sure.
Well, that's a whole other subject. I won't go there right now. That's a whole other podcast.
Yeah, that goes right into those danger signals that you were talking about. If you can't perceive that part of your body in space, that is very dangerous for your brain. But you brought up anxiety. Now that's super interesting because the literature talks about very clearly, and it's well-established links between hypermobility, chronic fatigue, fibromyalgia, and anxiety, specifically those three conditions. And it makes perfect sense to you, but in prepping for our conversation, the anxiety one didn't trigger my awareness until you mentioned it there, which is, wow, that's the link. It's an uptick in sympathetic tone?
Yeah, well, because you're defending yourself. You think inflammation is your body's, is at the simplest level. Inflammation, again, is a continuum. Okay. When you learn something, you shoot off a little inflammatory signal, along with dopamine. You need a little inflammation to remember stuff. You got to be aware because, our input is immense. Like how eyes, ears, all around us, it's just so much information. So you only learn what you pay attention to. And well, you actually use the same beginning of the inflammatory cycle to tell yourself to pay attention. Okay. But it's minor, boom, 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 little boom, booms, but if that gets stuck on, and that's what anxiety and that hyper arousal state is. It's self-protection gone awry. And that's what makes chronic disease so difficult, because for most of us, if you keep getting those signals, your frontal cortex begins to take over and just feels that there must be something very dangerous in the world. And we all have stuff to worry about, so you can keep worrying. It's anxiety. If you're sensitive people, okay, I'm going to jump into one other thing I want to make really clear, is that there's a great gift to be a sensitive person, to have a fine palate, to really be able to taste food, to be able to smell really well, to feel things, to notice the mood of others. All that stuff makes for a very rich and good life. But it comes at a price, is that when you get sick and you get inflamed, all those skill sets get ramped up. Okay. So, like if you're a little more on the dense side of things, if you're a little bit more on the dense side of things, like I said, I kind of am. I don't, you feel, but not quite as acutely. Well, then, you don't get as anxious. But when you're more sensitive, you get more anxious as well. And so when you have more inflammation in your body, anxiety gets driven, and OCD, the obsessive compulsive behavior, whatever, these are all survival things, okay? Because it all comes down to survival. Inflammation is your first survival tool. That's how you manage to live.
Sure.
We just got to keep it contained and keep life. So life is a dance. And if you're a clumsy dancer and you step on your own toes, and that's not good enough, but you make a mess. And so the point about this, again, but I keep pointing to the neck, is that when you have laxity at your neck and you stay inflamed, you often will start having more symptoms, and you won't know what's going on, because the neck might, you have a chronic neck ache, but the doctor doesn't, your neck hurts.
Sure.
But they're treating this rapid heart rate, or the constant diarrhea, or constipation, depending which way your gut is wired. So it's it's just important that people really see this as an interlocking story. Okay. You could have just a neck ache. If you have just a neck ache, you get a massage, you lie down, you rest, it goes away, all good. But if it's there every day, you should start thinking about it and paying attention.
So well said. Dr. Gordon, I admire so much the way that you practice. You have linked up all of these different components of medicine into a single congruent practice, and it's inspiring to hear you talk about it.
Well, thank you so much, Yoni, and do please call me Eric. I keep calling you Dr. Gordon. Oh, yeah. But what I really look forward to is interviewing you and sharing and learning more about how you view structure, because again, like I said, I learn a lot about many things, and just when people have a deep dive on a subject, it's so important, because that's where the learning is.
Yes.
And the sharing. So I really look forward to it, and it's a pleasure to talk to you.
Awesome. I'll be available. We'll set it up. Just let the audience know where they can find more about
yes, right.
and what you do.
Very GordonMedical.com. It's if people want to know more, there's a lot of information on the website, and if they're really interested in learning more, there's an info at Gordon Medical on the website. There's a button, and you can set up a time to talk to Rachel, who's our patient coordinator, and she really can give you a good idea of how we work and whether we're the right fit for you, because that's the important thing. We really like to see people who we can help. That's what makes it fun for everybody.
Thank you so much for watching. I really hope that you enjoyed this interview. If you'd like to know more about Dr. Eric Gordon and the exciting work that he's doing, I'll put his contact information in the description down below. And if you haven't done so already, please hit that thumbs up button and make sure that you're subscribed to the channel so that you're updated when the next video comes out. That's all for now. See you next time.